and welcome to our webinar, titled Ending the HIV Epidemic, A Plan for America, the HHS PrEP Program Stakeholder Webinar. My name is Harold Phillips, and I am the Chief Operating Officer for the Ending the HIV Epidemic Initiative in the Office of the Assistant Secretary in the Office of Infectious Disease Policy. Welcome to our webinar. Next slide. The audio is being shared via your computer, speakers, or headset. If you cannot hear the audio, make sure your computer audio is turned on and the volume is turned up. To ask a question, attendees are currently in listen-only mode. To ask a question about logistics, audio, or visual issues, please use the chat box. Click on the chat icon in your bottom toolbar to use it. To ask a question about content, please use the Q&A box. Click on the Q&A icon in your bottom toolbox to use it. Thank you very much. For our call today, we will first talk a little bit about PrEP, what it is, and what it means for our prevention options. Our speaker is Dawn K. Smith from the Centers for Disease Control and Prevention. Next, she will turn it back over to me, and I will talk about the Ending the HIV Epidemic with an emphasis on the prevention pillar and PrEP. We'll next hear from James McCrae, Associate Administrator, Bureau of Primary Health Care, the Health Resources and Services Administration within HHS. He will speak about the role health centers play in HIV prevention. And then we'll hear from Heather Houck, Deputy Associate Administrator of the HIV/AIDS Bureau at the Health Resource Services Administration within HHS. She will speak about the Ryan White program and the activities that they are engaged in, which also contribute to our overall work to end the epidemic. Overview of the HHS PrEP program, Dr. Tammy Beckham, the Director of the Office of Infectious Disease and HIV/AIDS Policy, will then present. She will also talk about the jurisdictional leadership and provider roles associated with the HHS PrEP program. We will then have time for questions, answers, and discussion, and we will end our call. Next, I will turn it over to Dawn K. Smith from the Centers for Disease Control. Dawn, are you ready?
I'm ready.
Okay.
Hello, everybody. So we're going to talk a little bit about PrEP, what it is, and why we want to scale it up for HIV prevention. Next slide. First, we're going to talk a little bit about where we are now with PrEP, and then we'll talk more about where we intend to go with the EHE initiative. So next slide. PrEP, for those of you who don't already know, is a treatment where people who do not have HIV, but who maybe have exposure to HIV, take a daily pill that will prevent them acquiring HIV. If PrEP is taken daily as prescribed, it blocks getting HIV during sex by up to 99%. So it is a very highly effective and safe method of HIV prevention. PrEP for people without HIV, in combination with treatment for people with HIV, work together to reduce new HIV infections in the US. Next slide. On the bottom of this slide is an indication about persons who have HIV infection. The blue box shows that about 15% of people who have HIV infection have not yet been diagnosed. They're unaware of their HIV infection. The blue box on the top shows that those 15% account for 38% of new HIV infections. 23% of persons with HIV infection have been diagnosed but are not in care, and they account for 43% of new HIV infections. Only 11% of persons who have HIV infection are in care but have not yet achieved viral suppression, and that 11% account for 20% of new HIV infections. However, in red, you have the 51% of people who have HIV infection who are virally suppressed. And one of the things that we have learned pretty clearly is that once you're virally suppressed, once you reach undetectable, you will not transmit to other people. So they account for 0% of the new HIV transmissions. For that reason, in the HIV initiative, we want to provide PrEP to people who are partners of persons who do not have viral suppression to protect them. But we also want to have more people diagnosed with their HIV infection in care, on treatment, and virally suppressed. These two things together will help us to achieve the goals of the end the HIV epidemic. Next slide. So in the past few years, since CDC issued its clinical practice guidelines in 2014, you can see that the number of people starting PrEP has increased each year. Most of that increase has been among men, and most of those men are men who have sex with men. However, while there's been an increase among women, it has been much less, a much smaller increase than has been seen among men. When we look by race ethnicity, what we see is that there's been a rapid increase among white MSM, among white persons. There's been an increase in Blacks and Hispanics and persons of other race ethnicities, but much less than that among whites. Next slide. The result of that is that when we compare the proportion of population that has indications for PrEP use to the proportion that are actually receiving PrEP in 2017, you can see that among white Americans, if you look at the bottom, the percent who are receiving PrEP is pretty close to the percent that have indications for PrEP. On the other hand, when you look for African Americans and Hispanics, the proportion who are receiving PrEP is much less than the proportion who have indications for PrEP and would benefit from its use for HIV prevention. Next slide. So now that we have a sense of where we are at the moment, we have to talk about where we're going next. Next slide. There's a good example of what can happen when we have rapid PrEP scale up in conjunction with high levels of persons with HIV infection with an undetectable viral load. In this sexual health clinic serving MSM in Canada, they looked at all of these parameters from 2011 to 2016. If you look at the far right column of the table, you can see that they started with a very high proportion of patients who were HIV infected who had viral suppression, 92%. And over the years that they were studying, it increased gradually to achieve 95% of all persons with HIV infection who had an undetectable viral load. At the same time, if you look at the next to the last column, you can see that there was a very large increase in the number of people who started on PrEP, going from 3 in 2011 to 729 persons in 2016. And then if you look at the second column, you can see that over that same interval, HIV diagnoses fell from 126 when they started to 82 in the last year. So this is a good demonstration of the fact that if we increase PrEP use, even when there are high proportions of patients with undetectable viral loads, we can have a marked improvement in the rate of HIV infection. Next slide. In the US, we tried to take a look at this in a little bit different way. We divided the states in the US into 5 equal groups called quintiles. Um, and and we divided them according to how much change in PrEP use had occurred from 2012 to 2016. And so on the left side, we have those that had the lowest increase in PrEP coverage. On the right side, we had those that had the highest. And what you can see is that in the 3 quintiles, the 3 sets of 10 states that had the highest levels of increasing PrEP rates, you had decreases in the estimated annual number of change in the number of new HIV diagnoses. So starting people on PrEP is one part of what we want to do with EHE. But the figure on the right tells us that it's not enough to start people on PrEP. We also need to build systems that keep them on PrEP for the duration of the time that they're at risk of exposure. In this cohort of a large number of patients who were seen in a single healthcare system, during the period of time when patients were not on PrEP, they had an annual incidence of HIV infection a little over 1%. During the period when they were on PrEP, that fell pretty close to 0. But of the patients who then stopped PrEP, they went back to have a very high rate, almost 1.2, I think it was, rate of new infections. So it's not enough to start people on PrEP. We also need to have systems that allow them to receive PrEP care in a way that allows them to stay on PrEP for throughout the period of time when they're at risk of HIV infection. Next slide. So now that you've learned a little bit about PrEP, we'll turn it over to Mr. Phillips to talk about the prevention pillar.
Thank you very much. Next slide. So ending the HIV epidemic, Plan for America, is based on 4 pillars. Diagnosing all people with HIV as early as possible after infection. So there are efforts across our government and efforts within community health centers and other places where HIV testing can occur, but we're also looking at other ways to bring HIV testing closer to the community in non-traditional settings so that people with HIV have the opportunities to be tested. Those who are diagnosed with HIV then under the treat pillar are linked as rapidly as possible and effectively to a treatment so that they may achieve and sustain viral suppression. The other pillar is the respond pillar, which will allow us to respond quickly to HIV outbreaks in communities to provide prevention and treatment services to people who need them. Today, we're going to spend a lot of time talking about the prevent pillar, ways to prevent new HIV transmission by using both proven interventions, including PrEP and programs. Today, we're going to talk a lot about PrEP, and the focus of our webinar today is the HHS PrEP program. With the plan to end the HIV epidemic in this country, we have an overall goal of reducing new HIV infections in 5 years by 75% and a 90% reduction in new infections within 10 years. As you just heard, more PrEP equals fewer HIV infections. And so it's an important part of the prevention pillar and the work that we are doing. Next slide. So this slide, I think, reiterates some of the key points from Don Smith's presentation about PrEP and PrEP use. We estimate that over 1 million individuals might benefit from PrEP, but only about 10% of those who could benefit are using it. Those who are not using it tend to be people of color, particularly African Americans, Hispanic and Latinx community, the American Indian and Alaskan Native community, and as well as women. We have seen, at least among MSM, that awareness of PrEP has gone up, but very often knowledge of how to access the medication, which programs individuals qualify for that could help with medications. That information is not out there as widely as it could be, which contributes to the low use of PrEP, even though we have indications that at least 1 million people could benefit from PrEP. So our HHS campaign is working to increase awareness and to also increase access and availability of this medication for those who can use it. Next slide. Next, we will hear from James McCrae, Associate Administrator for the Bureau of Primary Health Care at the Health Resource Services Administration, and he'll talk about the role health centers play in HIV prevention. Jim?
Great, thanks Harold, and good afternoon to those out here on the East Coast, and good morning to those out on the West Coast. So happy to be part of today's call. We're very excited that the HRSA-supported health centers are going to play a key role in ending the HIV epidemic. I think many of you know, but right now there are about 1,400 health centers that operate 12,000 service delivery sites across the country, providing healthcare services to more than 28 million people nationally. These centers provide primary medical care, including laboratory services. They also provide oral health services, mental health services. Increasingly, they're providing substance use disorder services, and they also provide key patient support services, including patient education, case management, patient navigators, as well as transportation. What we're really excited about is the role that health centers, we believe, will play around the whole area of HIV prevention. What we want to do with our nation's health centers is to make HIV prevention services a routine part of primary health care. If we can go to the next slide, or this slide, in terms of how we're going to get there, it's basically 3 approaches. The first is to expand access to PrEP through our HRSA-funded health centers. We're going to leverage the HHS donation program to make PrEP readily accessible to all of our health center patients, working with our colleagues in local health departments and other social service providers to get people into care and tested, and in particular to focus on uninsured patients who are at risk and who could benefit from PrEP. Dr. Tammy Beckham will talk more specifically about the HHS program, but health centers will be a key part of that. In addition, we have $50 million available for health centers in year 1 of the initiative, in fiscal year 2020, to expand their capacity to do more around outreach, to get people into care, as I mentioned, but to get them tested, get them linked to care if they test positive for HIV, and if they're HIV negative and at risk, to get them onto PrEP if clinically appropriate. One of the key indicators that we're going to be tracking with our investments in health centers is increasing the coverage for people for PrEP. And lastly, we know we can't do this without focusing on our workforce and really increasing their capacity to provide more services, more HIV services. So we're going to be building on our partnership with our sister bureau here in the Health Resources and Services Administration to expand the capacity of our health centers to provide more prevention services to our patients. If you can go to the next slide. It just provides a quick schematic of how we envision this working. Basically, we will be doing both outreach in the communities to get people into the health centers, but we also will be doing an increased amount of work to test our current patients. We know many of our patients may be at risk, but we have not been as vigorous as we need to be in terms of testing, and so we're going to be encouraging our health centers through this initiative to move towards opt-out testing rather than opt-in testing. We, of course, are going to test people as quickly as possible. As I mentioned, get them into care and linked to providers that can get their viral load suppressed if they're HIV positive. And if they are HIV negative, get them onto PrEP. We can go to the next slide. One of the things that's been really great through this entire initiative has been going out and talking to different health centers, other providers in the community, and to identify what are some of those best practices. And just a couple of things that I wanted to share, and these are going to be efforts that we're going to be encouraging our health centers to focus on, is to not just wait on having the health centers be the location where people come, but also to go out into the community. So have community outreach teams, do more work with respect to mobile vans, use peer educators, definitely collaborate with other community-based organizations, and also make sure that the systems are in place to help support the providers and others as part of the healthcare team to do that testing right from the very beginning. Speaking of prevention, the other key part that we've heard is to make sure that we do same-day PrEP starts as much as possible. When you have the opportunity to be able to get people into care and get them onto PrEP, Doing it the same day makes a huge difference. We also know the importance of reaching out in especially rural and underserved communities. Utilizing telehealth, teletechnology, teleprep is critical. And of course, having those PrEP navigators to help navigate the system, help people, number one, get into care, but also stay in care is absolutely essential. So we're very excited about doing all of this work. The nation's health centers are very excited about this opportunity, and we look forward to working with many of you on this initiative, not just this year, but in the years to come. So with that, I think I'll turn it over to my colleague in the HIV/AIDS Bureau, Heather Haw.
Great, thanks, Jim, and good afternoon, good morning, everyone. As most of you know, the HRSA HIV/AIDS Bureau implements the Ryan White HIV/AIDS program, which funds cities and counties, states, and clinics to provide HIV primary medical care, medications, and essential support services to low-income people with HIV. The Ryan White program currently provides these medical and support services to over 500,000 people with HIV, over half of all people diagnosed with HIV in the United States. In terms of our topic today, PrEP, the Ryan White HIV/AIDS program statute prohibits the use of Ryan White program funds to pay for PrEP medications or the related medical services for people who are HIV negative, as the Ryan White program is specifically focused on low-income people with HIV. This prohibition and these unallowable costs for PrEP medications and medical services not only apply to the Ryan White grant funds, but also to program income and to rebate funds generated through the Ryan White program. However, there are two areas in the Ryan White statute that do allow some HIV prevention-related activities, which includes PrEP-related education and training. And in addition to those two areas, there are some states and clinics that have been leveraging the Ryan White HIV/AIDS program infrastructure with non-Ryan White HIV program funds to support PrEP service delivery systems. In the next few minutes, I'm going to explain these two areas and this leveraging approach for the Ryan White program. Everything that I'm going to say today is also in, next slide please, the PrEP program letter that HRSA's HIV/AIDS Bureau released to our Ryan White program recipients on June 23rd in 2016. This letter recognized the importance of PrEP, the reason why PrEP is so critical, as Dr. Smith outlined. It acknowledges how the Ryan White program system of care and services can be utilized and leveraged, as I'm going to explain in a minute, and confirms our support of our Ryan White program recipients exploring ways to use the expertise and the infrastructure of the program to support PrEP. The first area where there is some flexibility is within our service categories. So within our Policy Clarification Notice 1602, we explain the core medical and support service categories where we indicate that there are components of a few of these service categories that are specifically related to PrEP service delivery. So for example, the first one is HIV testing and referral, which is a component of the early intervention service category. And that is embedded in parts A, B, and C of the Ryan White statute. That specific EIS, as we call it, component, HIV testing and referral, can be utilized in order to facilitate PrEP service delivery. The second service category is psychosocial support for affected family members, and this is specific to the Ryan White Part D program only. And this allows family members who may be impacted by people with HIV to receive psychosocial support, which could include counseling around PrEP services. And the third service category that can be utilized for PrEP service delivery is health education and risk reduction services. Now, this is health education and risk reduction services for people who have HIV, but part of that education is around strategies to reduce transmission for exposed partners, and this, of course, could include PrEP education and risk reduction services. And that service category is in parts A, B, C, and D of the Ryan White statute. So with those three service categories that can be used for PrEP, it does provide a limited flexibility to provide PrEP services for people who do not have HIV. The second area where the Ryan White statute provides authority to support HIV prevention activities, including HIV testing and PrEP training and education, is through the AIDS Education and Training Center program, which Jim just alluded to as well. Our regional AETCs have a long history of providing training to primary care providers on HIV testing and more recently, certainly on PrEP. Many of them have specific training curricula. And in addition, the AIDS Education and Training Center National Coordinating Resource Center, or NCRC, has a number of those curricula and other tools and educational materials related to PrEP on its website that anybody can access. And lastly, in the Ryan White AETC space, we have our National Clinical Consultation Center, or our NCCC, which operates the PrEP line and a PEP line for clinicians. And this is funded in concert with CDC. And the NCCC provides critical support to clinicians who need information on when and how to provide PrEP services to patients in their clinics and medical settings. So those are the two areas where there are opportunities for helping support PrEP services through the Ryan White HIV/AIDS program. And last, as I mentioned, there are examples of states and clinics leveraging the existing Ryan White program infrastructure. Now, again, this must be done with non-Ryan White funds because we do have the statutory prohibition on using the grant funds, program income or rebates, for PrEP medications and related medical services. But a number of states have leveraged their ADAP program, for example, with non-Ryan White funds to set up PrEP DAP programs to help patients navigate how to access PrEP medications. Many clinics are operating, utilizing their case managers and their case management systems and their clinicians, again, leveraging the Ryan White expertise and infrastructure with non-Ryan White funds to use those staff to help with PrEP service delivery. So those are just a few examples of how the infrastructure of the Ryan White program can be utilized with non-Ryan White funds in order to build on that expertise and capacity. So all of the resources I've mentioned and the guidance that I've described are again on our, next slide please, are on our HRSA website or the AIDS Education and Training Center, National Coordinating Resource Center website. In the context of the Ending the HIV Epidemic initiative, we do plan to supplement, again, assuming the funds are appropriated and we're provided the authority to do so. We plan to supplement the AETC program to expand the training and technical assistance for HIV service providers to implement PrEP, and working specifically, as Jim mentioned, with our health center program partners, as well as other providers interested in implementing PrEP services. We also plan to continue to encourage the leveraging of the Ryan White program infrastructure with non-Ryan White funds in order to expand capacity for PrEP services in states and clinics. So that was a very quick overview of the Ryan White program's work in helping to support PrEP in the Ending the HIV Epidemic initiative. I hope it provided you with the information you need to understand how we can do that. Again, although statutorily prohibited from directly providing PrEP medications and medical services, we do have a number of ways where we can support training and technical assistance, using some discrete service categories related to PrEP education and counseling of patients, and again, infrastructure development through leveraging the program with non-Ryan White funds. I'll be happy to answer questions at the appropriate time in the webinar, and at this point, I'm going to turn it over to Dr. Tammy Beckham.
Thank you, Heather, and thanks everybody that has spoken prior to me. You guys have done a great job laying the foundation about PrEP and why it's important, and where we're headed with the Ending the HIV Epidemic, and the role of the optives and the qualified health centers, et cetera. So thank you so much for that. So I'm going to spend just the next few minutes talking about the PrEP donation itself and a little bit about implementation and distribution of that medication, and then a little bit about the program and so forth, and then we'll take some questions. So first, I think many of you know that Gilead donated Truvada for PrEP to HHS, and we announced this on May the 9th of 2019. This donation was meant to go to patients that have no prescription drug insurance, and so I'm going to talk a little bit about eligibility here in just a second. But they provided enough medication for 200,000 people per year to utilize the donation. As a result of the donation, Gilead provided just what I said, which was the medication. HHS bears all other costs for the distribution of this product out to patients that have an indication. And those other costs include verifying patient eligibility, enrolling the patients, utilizing that big network of participating pharmacies, which is about 65,000 pharmacies nationwide, and then getting the donated medication out to the patient, literally, and then processing claims with regards to the donation itself. So that is a very complex process, and it takes a whole infrastructure to make sure that we can make that happen. And as such, and as you guys know already on the phone, there are a lot of those medication assistance programs out there that have that network in place. For us, HHS, to go through a full and open competition to have that infrastructure developed for us to distribute the program would take quite a long time, probably up to a year for us to go through our competitive bid process. The donation that Gilead provided is a limited term donation, up to 10 years. And so we wanted to make sure that we could get this medication out into people's hands as quickly as possible. So in order to do this, we put together a 6-month contract with Gilead, utilizing their subcontractors that they already have in place for their Advancing Access program, so that we could leverage that infrastructure and utilize that to get medication out to patients quickly. So having said that, this is a 6-month contract with an optional period for another 6 months. Basically, we have to build utilizing the Advancing Access infrastructure and their subcontractors. We have to build that program and that infrastructure for an HHS program. So that is what we're currently doing right now. We're working with them very closely to leverage that infrastructure, and we'll be able to do this in a much shorter period of time than it would have taken us to go out for a full and open. Having said that, during the 6 months that we are now working with Gilead to get this up and running and to get pills out into people's hands, or Truvada out into people's hands, what we're doing is we are getting ready to, in the short term, go out with our full and open competitions for the next 5 years to select a contractor that can distribute this medication for us. So next slide, please. So I just wanted to kind of go through how the program is going to work so everybody is familiar with that. So first of all, for the first 6 months, given the fact that we had to ramp up a little bit and we had to put the infrastructure in place, we anticipated that we'd have around 40 to 50 patients, 4,250 patients in the first 6 months that would access the program. And then we, as I said before, we have an additional 6-month option period for this contract where we would have up to 10,000 patients allowed for within the first year. Having said that, for a patient to qualify for this program, there are only 3 things they have to have. They have to have a lack of health insurance for outpatient prescription drugs. They have to have a valid on-label prescription, and they have to have the appropriate testing, lab testing, showing that they're HIV negative. We are in phase 1 of, in this rollout with Gilead in the 6 months. We are, this is a nationwide rollout. So any provider nationwide that has a patient that comes in that has an indication for PrEP would then be able to access this program through a call center or through an online portal, much like you currently access the Advancing Access program now. The difference between our program and the Advancing Access program are the eligibility requirements as far as accessing it. So we have a lack of health insurance as outpatient prescription drugs as a qualification for ours. The Advancing Access program has different qualifications for theirs. So as I said, a provider that has a patient that has an indication nationwide can access this program through a call center or through an online portal. And have those up and going in a very short term, and we're working on that now. And we've been working closely with all of our partners. So I want to just walk through the slide that you see here really quickly. Patient goes in to see a physician. determines that PrEP is appropriate for that individual and there is an indication for that, the provider writes a prescription. They can also access the call center at the provider's office, or the patient themselves can call into the call center, or they can do it online through the portal. Once that happens and the patient is determined eligible for the program, then they will receive a card like you see there on the right that has a BEN number on it and an ID number, group number. They can then take that card and go to the pharmacy, brick and mortar pharmacy, or they can go to the community health center pharmacy, and they can get a prescription for PrEP. So that's how the program is going to work. And again, we're going to roll this out nationwide, but obviously because the Ending the HIV Epidemic is focused on phase 1 jurisdictions, the 48 DC, San Juan, and 7 states with high rural burden, we're going to focus our education and awareness efforts in the phase 1 jurisdictions as part of the Ending the HIV Epidemic. Next slide, please. So we've heard a lot about PrEP today, and as we all know that we have to have a robust education and awareness campaign around the HHS program. If we don't, number one, people won't understand how to access the program and how to gain access to the program and take advantage of having this opportunity for PrEP. The other thing is that we want to educate folks around PrEP, and those that might have indications for PrEP, we want to make sure there's a lot of education and awareness around it. So at the same time that we signed the contract with Gilead for 6 months, we also signed a contract with a company to help us develop some brand identity and some materials, educational materials around this program. And so given our urgency to want to build the program and to leverage the infrastructure that Gilead and their subcontractors had in place, what we've been doing also at the same time is developing some materials that will help educate not only providers, but also potential patients on how to access the program and what the eligibility requirements are, et cetera. And so we have been creating those materials, and we'll be pushing those materials out when the time is right. And when we're ready to go live with this program, we'll be pushing those materials out through providers, through provider organizations. We'll be working with our stakeholder organizations, our advocacy organizations. We'll be working nationwide with our pharmacies, pharmacy chains, state and local health departments, federally qualified health centers. We're going to push materials out far and wide so that we can get the word out about the program, how to access the program, why it's important, et cetera. And then once we've done that and we go live, which again, we're hoping is sometime in early December, sometime next month, we're going to then move out into phase 2, which would be a more robust education and awareness campaign. I've been out in jurisdictions, talked to folks. I know there's a lot of materials out there already that have been developed specifically for jurisdictions around PrEP. We don't want to recreate the wheel. We want to work with you. We want to work with the community because you already have culturally appropriate education and awareness materials about PrEP out there. So we just love to work with you guys, and that's what I'm going to say there. But it'll be a very large integrated approach across many different media platforms. So next slide. So we're doing the webinars today. You can see that up here on the calendar, and that we did a webinar earlier today with our federal staff as well. We're really counting on, next slide, really counting on you guys to help us get the word out about this program. The most important thing that we can do, I mean, obviously enrolling patients and getting this stood up is critical, but we also have to get the word out about this program, which is why we're holding this webinar today. So we would love for you guys to start talking about this program. You know, we're going to have more information to share in the short term, I hope. And we're, you know, help us work with our providers, help us work across with our community-based organizations and within these jurisdictions and even nationwide, as I said, to get the word out, work with our healthcare providers, work with our state and local organizations, our community-based organizations, and really work together as a team, because the only way we're going to be able to end the HIV epidemic and the only way we're going to be able to meet our goals with PrEP as well and get this benefit out to the people who need it is to make sure that we're getting the word out there about the eligibility and about the program. So we would love for you guys to help us do that. So that was one of the purposes of this webinar today. Next slide. So just more community roles. Again, I think, you know, helping us, and we're gonna ask you over the next several weeks to help us push messages out. We're gonna ask you to help us push materials out. We're going to want to hear from you about what works and what doesn't. And as we get out into the second phase of the campaign, we want to understand what messages are working. And we know the communities have this. We know a lot of the national organizations have this, and we want to work with you guys to make sure we leverage what you already know. So next slide. So having said that, I think I'm going to turn it over to Mr. Phillips. We're going to be able to answer questions. We have a little bit of time left, and I see there's a lot of questions in the queue. So let's get started on the questions. And thank you guys for joining us today. We really do appreciate it.
Thank you, Dr. Beckham, and thank you to all of our presenters this afternoon / this morning. A lot of you have asked, will slides be available? We will make a summary of this call available on hiv.gov. So our next question, will PrEP only be available to uninsured patients in all states? Dr. Beckham?
So PrEP will be available to those patients that do not have prescription drug insurance, that test negative for HIV, and have a valid on-label prescription. Those are the 3 criteria for qualifying for this program.
Sure. And does that include individuals on Medicare or Medicaid who can benefit from this program?
Again, 3 qualifications for the program: HIV negative, lack prescription drug insurance, and a valid on-label prescription.
Great, thank you. And this one goes to HRSA, to Mr. McCrae. There's a question about the wrong door, no wrong door for HIV testing. Can you say a little bit more about that and what it means? And Jim, I think you might be on mute.
Can you hear me now?
We can.
All right. So no wrong door basically means that if somebody comes in for a medical condition, or if somebody comes in for a dental appointment, or somebody comes in for a substance use disorder service, that you basically do HIV testing if that person is potentially at risk following the CDC guidelines. And so you don't, follow just sort of the traditional path of they come in for a medical exam. There really is no wrong way for somebody to come in. We can work on the jargon. I think somebody mentioned that we could try to think of better language, so we will try to do that. But that's the basic intent, is that for HIV testing, it's not just medical. It really is any way that somebody comes in and enters the health center.
Great, thank you very much. There's another question in the chat box about help for individuals with prescription drug coverage who cannot afford PrEP. And what I will add is that this HHS program is a new program. Dr. Beckham has talked about the qualifications for those, the eligibility requirements for those who qualify for this program. And we are targeting those who do not have prescription drug coverage. But there are already existing programs for those who do have prescription drug coverage. And if you go to hiv.gov, which can point you to a PrEP navigator or PrEP program, there are navigators who can help you figure out which programs you qualify for and how you can access PrEP. But as well as the National Association of State and Territorial AIDS Directors website, they have a list of different PrEP programs across the country. Once you access a PrEP navigator, they can help you figure out which program you qualify. But this HHS program is an added program, so those other programs are not going away. There are a lot of questions about lab costs and how they are dealt with or addressed. But in this HHS program, we are not covering the cost of labs. But I will turn it over to our HRSA colleagues who might talk about how that's covered in our HRSA and CDC colleagues who may talk about how that's covered in some of those settings. Jim or Don, whoever wants to go first.
Sure, I can start, Harold. So in terms of for the community health centers, as part of the $50 million that we're making available to about 200 health centers in this first year, resources will be available to help support basically people with medical care services, including labs. Those services will be charged on a sliding fee scale basis, but basically the intent is that those costs would be nominal for someone who is living in poverty, and on a sliding fee for somebody up to 200% of poverty.
Hi, this is Dawn from CDC. In addition, there are some states and local jurisdictions that have their own PrEP assistance programs. Some of them cover laboratory costs and clinic visit costs. So you can find a list of those on the NASTAD website.
Thank you, Don. Also, those of you who are following along in the chat box, you may see that some of the questions have been answered in the chat as well as we go through. Question from Dwayne Ford, will Gilead also provide Descovy in addition to Truvada? And the answer to that is yes, for our HHS program, both drugs are available. Okay. Great. This might be a question for Jim McCrae. This one is, if an FQHC has an on-site pharmacy, could patients use their PrEP vouchers there versus going to an external pharmacy? And the answer to that is, yes, they can. And I don't know, Jim, if you are off mute, if you want to elaborate a little bit more on that.
Yes, so the answer is that people can use either their on-site community health center pharmacy, or they can use a contracted pharmacy that the FQHC utilizes. And most of our health centers have some aspect of both on-site as well as contract.
Great, thank you. So there is a question about our message to women in PrEP. As we talked about both, I think, in Dawn's presentation as well as my presentation, there are women who are included in that 1 million estimate of those who could benefit from PrEP. Yes, and so Truvada is approved by the FDA for use in women. And so through our HHS program, those who meet the qualifications can access Truvada through that program. Currently, Descovy, there are certain concerns around that, not approved by FDA at this point in time for use in women. So Truvada is available. And our next question, how will patients with no insurance access a physician to write the prescription, and will HHS cover the cost of the physician services? So, HRSA?
Thanks, Harold. So we're encouraging folks, especially in the target jurisdictions, to visit their local community health center. Within the targeted jurisdictions, there are about 500 health centers in those 48 counties, Washington, DC, San Juan, and in the 7 rural states that have been disproportionately impacted by HIV. People, can come into their local community health center, get access to services. They can actually find their local health center by going to our website, or even on their mobile phone, find a healthcenter.gov, and they can just type in their zip code and they can find their most local health center, and they can set up an appointment.
Thank you for that. Those of you who are looking for data that includes ethnicity for MSM and data on other communities, I encourage you to go to the CDC website. It's a great resource. Their Atlas Plus also has a lot of really great data and slides for use for those who want more information about racial, ethnic, or gender breakdowns when it comes to HIV or PrEP usage as well. John, do you want to add any more to that about sort of the CDC resources that are there and available?
No, I think you gave a good representation.
Lovely. I love it when that happens. Also, Jim, there's one question about, can you kindly elaborate more on teleprep? And I know that we are currently looking at different models and different ways to provide effective PrEP services, really ways to make it easier and more convenient on the populations that we're seeking to make sure have access to this great new prevention tool. But there's a specific question about teleprep.
Sure. So there are a variety of different mechanisms that health centers and other providers have used with respect to teleprep. There's one that we've highlighted on our website that's with the Iowa Department of Health, where they've created a statewide HIV PrEP program. And it basically is run through both community health centers, other clinics, as well as through telemedicine. And basically what it consists of is telemedicine video conference appointments with a dedicated PrEP clinical pharmacist who works with a supervising physician. A physical exam isn't needed to be able to do this, but during the visit, the clinical pharmacist talks to their patient about their sexual and medical history. They look at the lab work that the patient has conducted. And then as appropriate, they will prescribe the PrEP medication. And to participate in the teleprep program, all folks need is basically a smartphone, a computer, or a tablet. And it does work on, in Iowa's case, on a low broadband network, which we know has been an issue in a lot of our rural communities. So that's one of the things you can look at on our website, dphc.hrsa.gov, under our promising practices for health centers.
Thank you very much for that, Jim. Question from Peter Lowett. Do patients need a social security number in order to qualify for a prescription assistance program?
Patients just need an address in the United States to qualify for that.
Great. Thank you very much, Dr. Beckham.
So there's another question here from Sandra Miranda. When will the program begin? Is there official launch date? We are working very diligently to roll the program out in early December. I don't have an official date for you yet, but we're looking at the first half of December likely for that, if not a few days on the other side of that. So working diligently to make sure that that December timeframe works. There was another question I saw up here. Is HHS paying Gilead for the drugs that Gilead donated? And so no, I want to make sure that everyone understands that no, there was medication that was donated from Gilead, and that was the medication that was donated. In order to get that drug out into the hands of people though, obviously there has to be a distribution network. And so what HHS did do is we have awarded Gilead a $6 million contract, but the money is going to their subcontractors, their 65,000 pharmacy network, et cetera, and all their subcontractors, wholesalers, et cetera, to distribute that drug for 6 months for us under a 6-month contract with the optional 6 months. At that same time, we're going out with a full request for proposals, full and open competition to identify another vendor that can do that for us for the next 5 years and negotiate best price for the federal government for that to happen as well. So I want to make that very clear that the federal government is not paying Gilead for the donation of the medication. The donation is exactly what I said. It's a donation of the medication for 200,000 patients per year for Truvada or Descovy. And we've also got that posted on hiv.gov as well.
Thank you. It looks like we have time for a couple more questions. So we will tee some of those up as well. We did that one. And right. Will case managers and social workers have access to the portal for the PrEP program? Yes, we will have access. We will make sure that as we do our nationwide rollout, that access to the portal is available widely, as well as the phone number. Clients, as well as their providers, will have an option of whichever way they feel comfortable, either accessing and enrolling in the program through the web-based portal or through the phone. So a lot of the questions we have Heather, Jim, while we scroll through to see if there are other questions that we need to cover that we haven't already covered, is there anything else that you feel like we should add at this point in time?
Nothing from our end. I think the biggest thing is we're just working with our community health centers to expand their capacity to do more in HIV. We have a lot of champion health centers out there, but through this initiative, we really hope to expand our footprint of what health centers can do around HIV prevention as well as diagnosis, and look forward to working with many of the folks on the phone to expand our capacity in that space.
Right. Heather, Dawn?
Likewise, from the HIV/AIDS Bureau, we're looking forward to, again, working with our AIDS education and training centers to help expand provider capacity, and specifically working with the health center program clinics to help them expand their capacity for PrEP services.
Yeah, and at CDC, we're continuing work on improving our guidelines and on doing provider training and education through our technical assistance channels.
Great. Thank you all very much. There was a question earlier around, and maybe this is a question for Dawn. Dawn, can you explain why indications for PrEP for African Americans exceed those for whites?
The indications for PrEP use are not different between blacks and whites, but because the prevalence of HIV infection is higher in the African American community, the likelihood of being exposed to HIV is higher in the African American community. That translates into a larger proportion of African Americans who have indications for PrEP, who would benefit from the use of PrEP.
Great, thank you. There was also a question about, will the program be available in the U.S. territories? Yes, as Dr. Beckham stated, this is a nationwide program. Any prescriber in the United States and its territories can prescribe and refer individuals to the program, and if they are eligible and qualified, they can receive medications through this program. Puerto Rico is also one of the phase 1 jurisdictions of the Ending the HIV Epidemic. Materials for this program, when they are rolled out, will be developed in English and in Spanish as well. So thank you all for the questions. Unfortunately, we will not be able to get to all of them. All 172 questions. We will have many of these questions and the answers or responses posted to hiv.gov, and we will also have a summary of this call. We thank you all for joining this call and for your interest in both the Ending the Epidemic initiative. For more information about the initiative, we encourage you to join our listserv. It's on the screen right now on hiv.gov, and subscribe to that to get updates and more information about this program and other activities that are happening across the federal and the local space with regard to the Ending the HIV Epidemic. Again, we wish to thank you. This is an important aspect of our prevention efforts and our efforts to end the epidemic in this country. We also, if you click on the link that will appear at the end of this session, you can give us feedback on today's webinar, and we thank you very much. Have a great day and a great weekend.